Vijayalakshmi ma'am.
Good afternoon all. Today I am going to speak about counseling of negative outcome in ART, an evidence-based approach according to ISAR, HG and Fertility and Sterility journals. Counseling should begin before any treatment starts. Throughout the treatment process, at each and every step we need to counsel and explain both wife and husband together, the couple together, before any treatment starts and not after failure occurs. Because ART improves the probability of pregnancy and does not guarantee pregnancy. The success depends on multiple biological factors and not every single cycle will result in implantation, positive pregnancy or live birth. Our main role is to improve the chance of pregnancy and not to guarantee the pregnancy. Why does this counseling actually matters? Because what usually all the patients believe is simple ovulation induction or simple follicular study or IUI or every IVF cycle guarantees 100% pregnancy, all good quality embryos always implant, embryo transfer is equal to success, IVF can overcome all fertility problems. But the clinical reality is ART is a multi-step biological process with several potential points of failure and all the failed cycles cause significant anxiety and depression. 25 to 30% of the couples discontinue due to emotional burden even with a reasonable prognosis. The goal should be the live birth is the true endpoint of the fertility treatment and not a positive pregnancy test. Counseling should start with explaining the probability of success at each and every point of the treatment. Even at the beginning of the natural cycles, we need to counsel them that each cycle, the chances of positive results are 10 to 15% per cycle. In IUI, it is 10 to 20%, max 20 to 25%. Here also, it depends upon the female age, egg quality, sperm DNA, and the tubal function in case of natural or IUI cycles. Even in IVF cycles, only when 2 day 5 good grade embryos are transferred only, the success rate is around 30 to 55%. Because there are many factors which cannot be accurately measured beforehand, like egg quality, sperm function, tubal function, endometrial receptivity, and embryo chromosomal competence. We need to counsel them that no fertility treatment offers 100% guarantee of pregnancy or live birth. Where does actually the ART fails? 60 to 80% the causes lies at the level of embryo or oocyte, 10 to 20% at the level of endometrium or uterus, 10 to 20% at the level of sperm, 5 to 15% are due to infections or inflammation, and less than 5% due to immune disorders. And most of the ART failures are multifactorial. The success requires consecutive wins at each and every step. We need to evaluate at the level of gamete. It requires the production of healthy egg and sperm, which should be good quality and they should be chromosomally normal. And in case of natural IUI cycles, there should be functionally normal tube, not just open or patent tubes. At the level of the embryo, it relies on successful fertilization, continuous embryo development and healthy blast formation. In the maternal phase, it requires optimal endometrial receptivity, implantation, immune tolerance and placental development. After each ART cycle failure, we need to do stepwise reassessment. At the level of embryo, we need to recheck the embryo quality, blastocyst rate and assess the aneuploidy risk. Male factor, we need to recheck the semen analysis, DNA fragmentation index whenever needed, uterus and tubes, 3D ultrasounds and hysteroscopy if not done prior, and need to evaluate tubes for hydrosalpinx and endometrium for tuberculosis. In maternal condition, we need to rule out any chronic medical disorders like diabetes, hypertension, thyroid or any infections or chronic endometritis. And the most common cause of ART failure are chromosomal abnormalities, aneuploidies. These are directly responsible for failed implantation, biochemical pregnancy loss and early miscarriages. These are recurrent implantation failure or severe male factor. We need to consider genetic counseling, couple karyotyping and embryo testing whenever needed. The impact of age on embryo aneuploidy should be explained, counsel to the both couples. We need to explain that female age remains the strongest predictor of IVF success and embryo competence. In less than 35 years, the aneuploidy risk is around 30 to 40%. In 38 to 40 years, the risk is around 60 to 70%. More than 42 years, the aneuploidy risk is around 80 to 90%. We need to counsel that IVF can increase only the chances of pregnancy but cannot completely overcome the ovarian aging. And the second factor which is needed for the foundation of the success is the egg quality. Oocyte competence is very much important. Importantly, the egg quality declines even before egg quantity. The causes of poor egg quality are advanced maternal age, decreased ovarian reserve, PCOS, metabolic hormonal dysfunction, obesity and lifestyle factors. How to improve the egg quality? Evidence-based measures like optimization of BMI to maintain between 20 to 24. They can follow the Mediterranean diet, strict glycemic control, stop smoking if any. They should have adequate sleep and regular exercise, individualized ovarian stimulation, and possible adjuvants like coenzyme Q10 300 mg and DHEA can be given in selected decreased ovarian reserve patient. And we need to counsel them that no treatment completely reverses the ovarian aging. And the third factor which we need to reconsider in ART cycle failure is we need to recheck the sperm count, motility and morphology and DNA fragmentation index in needed cases, and we need to counsel the couple that normal semen analysis does not guarantee the normal sperm function. The causes of sperm DNA fragmentation index is raised DFA is associated with poor blastocyst development, implantation failure and recurrent miscarriages. And this high DFI compromises the paternal genomic contribution to the embryo. And the common causes of raised DFI are varicocele, infections, smoking, obesity, heat exposure and oxidative stress. How to improve sperm DFI? Even before starting the treatment, we need to advise them to stop smoking or any habits if they have, to optimize the BMI, weight reduction, varicocele treatment in case of grade 4 or grade 3 with severe symptoms, antioxidant supplements for 3 to 6 months prior to start of treatment, treat underlying infections, reduce the occupational heat exposure, and in selected IVF failure cases, we can repeat the DFI to monitor the progress and consider testicular sperm retrieval to bypass the epididymal oxidative stress. And the main story lies in the embryo quality. We need to counsel the couple that a beautiful embryo is not always chromosomally normal. Major causes of embryo failure, it could be due to aneuploidy, mosaicism, developmental arrest and mitochondrial dysfunction. The other factor which we need to recheck after ART cycle failure is chronic endometritis. This is prevalent in 10 to 30% of patients with recurrent implantation failure. Chronic endometritis, this reduces the endometrial receptivity, it increases the risk of implantation failure and it is associated with early pregnancy losses. How to diagnose and treat the chronic endometritis? This can be diagnosed with hysteroscopic findings where we can see like hyperemic or hemorrhagic spots or patches, strawberry spots and small micropolyps can be seen in hysteroscopy, and in endometrial biopsy there will be raised plasma cells or CD138 can be seen. For this, empirical treatment can be given like injection ceftriaxone can be given stat dose along with augmentin, minocycline and some probiotic for 12 to 15 days twice daily, and we can recheck the CD138 if it is positive or rebiopsy it after 2 weeks after completion of course. If still CD138 is positive, we can give second line drugs with tablet levofloxacin along with metrogyl for about 12 to 14 days. And the main thing is we need to recheck after failure at the uterine factor. We need to recheck any structural causes, any polyps, submucosal fibroids, adhesions, IRAK and uterine septum or hydrosalpinx. Most of the factors can be corrected by hysteroscopy, and if any hydrosalpinx is there, we can do either salpingectomy or proximal tubal occlusion before the next treatment process. Because the hydrosalpinx, this can reduce the implantation rate by approximately 50% due to backflow of embryotoxic fluid. And the sixth factor which we need to recheck are the immunological causes. It can be due to antiphospholipid syndrome or autoimmune disorders. The seventh factor which we need to recheck after ART failure are the hypercoagulable conditions like ABLA or inherited thrombophilia, which are responsible for implantation failure, placental insufficiency and recurrent miscarriages. For hypercoagulable conditions, we can treat with low dose aspirin or low molecular weight heparin. We need to rule out other maternal systemic and comorbid factors like obesity, thyroid dysfunction, diabetes, hypertension, endometriosis or vitamin D deficiency, which are responsible for decreased implantation, which reduces the overall fertility and the possible adverse effect on receptivity. We need to optimize the maternal health before repeating the treatment. The ninth factor which we need to recheck after failure is the endometrial receptivity assay. This may be considered in case of after recurrent implantation failure despite transfer of more than 4 good quality embryos. We need to counsel the patients that the embryo is a seed and the endometrium is equally important for a good quality embryo to implant. Counsel about the modifiable and non-modifiable factors. We need to counsel them that female age, ovarian reserve and genetics are non-modifiable factors, and we need to counsel them regarding the modifiable factors which can be improved before the next cycle. Modifiable factors like BMI, smoking if they have any they should stop. They need to correct diabetes, hypertension, thyroid. They need to make lifestyle changes. Hydrosalpinx if it is there, we need to occlude or disconnect the tubes. We need to treat the infections and endometritis before proceeding to the next cycle. Approach after ART failure, we should not repeat the same thing without reassessment. A failed cycle should not automatically lead to the repeating the exact same protocol, because every failed cycle it provides us valuable information, and we need to learn from the cycle, identify the cause whenever possible, and utilize the next treatment plan. What not to do? The take-home message is we need to counsel before stimulation starts and at each and every step of treatment process. We need to counsel that female age and egg quality are the strongest predictor. We need to evaluate embryo, sperm, uterus, and tube systematically, and do not automatically repeat the failed protocols. We need to counsel them that aneuploid is a major determinant and most of the factors are multifactorial, and avoid unnecessary investigations and add-ons, and correct the modifiable factors and give the individualized care. The mistake is not treatment failure, but the mistake is repeating the same treatment without understanding why it is failed. Our goal should be like one healthy baby and one healthy mother at the right time. Thank you.
It's a very nice presentation.